Testing 1 2. Test test test. Testing 1 2.
I've been there for about 15 years, and I appreciate the invitation to come speak with you all, and I'm talking on what probably is my favorite subject, rheumatoid and psoriatic arthritis. The title and the focus of the talk is a little bit more specific, and frankly, I think probably a little bit more useful than even the talk title that you were given. The slides are somewhat different and updated compared to what you have, but I'm happy to send them to you. So probably better not to try to follow along, but I'm happy to make any of this available to you after the fact. So I've titled this talk Towards Remission. So this is a word, the R word, that we never used to talk too much about in rheumatology because nobody could ever really get there. Even back in the days when people used gold, and that's nearly before my time, they hardly used to ever talk about remission. But in the year 2018, this is now a viable target for people who have inflammatory types of arthritis, including rheumatoid and psoriatic arthritis. These are my acknowledgments and disclosures, none of them directly related to this talk. So let me just level set something that may be familiar to all of you, but maybe less familiar to some of you. So one of the things that I like about being a rheumatologist is everybody that you meet who's an adult either has arthritis or will get arthritis or has people in their family that have arthritis. So, you know, what you do is typically pretty relevant to most individuals. The focus of the talk is going to be on rheumatoid arthritis, or RA, and I wanted to remind you what we're not talking about. And one of the nice things about rheumatology, when you're diagnosing arthritis, pattern recognition is a big deal. So I suspect that if you're over the age of 50, you have or likely are developing osteoarthritis. That's the kind that most people get if they live long enough. Women more than men, a little bit earlier. But let me just point out some of the features. The joint distribution is incredibly helpful. So your DIPs, your distal interphalangeal joints, that's what's out here, or your PIP, your proximal interphalangeal joints, and the base of the thumb, those are the target joints in osteoarthritis. You may remember from medical school, you know, Bouchard's and Heberden's nodes. That's the bony enlargement that we see for people that have osteoarthritis. And in fact, it affects typically your second and your fifth digits first. So if you felt your own second and fifth digits at the very end, that joint, if it sort of feels like you've got some bumps there, or you know, you need rings resized, then probably that's the origin of that. And that's the condition in which we see bony enlargement. In contrast, the joint distribution for RA is quite different. The wrist is involved. Osteoarthritis never involves the wrist, but rheumatoid does. And the MCPs, the metacarpal phalangeals. Basically, if you make a fist and you're going to punch somebody, you know, it's your knuckles here. Those are very, very commonly involved. And your PIPs can and often are involved, but pretty much never your DIPs. So, you know, if your distal joints are involved, that's not rheumatoid, or at least it's not only rheumatoid. So that pattern recognition is huge. If somebody comes and they basically have bilateral knuckle swelling at the MCPs, particularly if they have a rheumatoid factor that's positive, but you know, bilateral MCP swelling, that is never normal, that is never, you know, osteoarthritis or the regular kind that people might think of. Now, osteoarthritis also can affect, and often does, the back, typically the low back and the cervical spine, knees and hips, those are weight-bearing joints, as well as your big toe, the first MTP. Not all first MTP joint arthritis is gout, although that's obviously prototypical. RA can affect almost any joint, but thankfully not the lumbar spine. Gelling is very common in osteoarthritis, so people will say, you know, when I sit down for more than, you know, just a few minutes and I try to get up, I kind of feel stiff, and it takes a couple minutes, you know, usually 10 or less to kind of work it out. Most people, some of you nodding your heads, like everybody has that over age 40. I have that. So, you know, this is common. This does not mean that you have a rheumatic disease that's inflammatory. In contrast, somebody with rheumatoid will complain of profound, prolonged morning stiffness. You know, everybody should get 10 or 20 minutes, you know, you take a shower till you limber up. People with rheumatoid, you know, they're in their often 30s, 40s, and 50s, and they're stiff for an hour or two, sometimes all day. So quite a different pattern, and the duration is much, much longer. Osteoarthritis, the wear and tear kind of arthritis, you know, you're bone on bone, there's no more cartilage, pain gets worse with activity. You know, the more you use it, the more you're up and about, your back hurts more, your knees hurt more, your hips hurt more when you go jogging or walking. That's kind of the pattern of pain you expect when you're dealing with OA. In contrast, if you're using those joints, there's lots of activity, you're actually working out that inflammation. People with rheumatoid and inflammatory arthritis typically feel better as they exercise. Now, eventually, if you overdo it, then you're going to hurt worse again. But noon may be their best time of day if they've been able to be physically active for a while. So the pain with RA improves with activity. The swelling of the joints is typically in OA bony. You feel your fingers or the base of your thumb. I mean, it just feels like there's bony enlargement. But in contrast, we have what we call synovitis or synovial swelling. It's basically this mushy, spongy feeling that you can't really feel like the edge of your joints, and you get the sense this is not just bone here. There's what feels under my fingers like I'm dealing with a mushy sponge. Inflammatory markers are typically elevated, but not always in RA. They're generally normal in OA, but of course people can have lots of reasons that your SED rate or your CRP is elevated. So the pattern of joint involvement and some of these characteristics are quite important to differentiate. The prevalence also matters. Rheumatoid affects about 1% of adults in the US, and the mean age of onset is about 48 to 50. Women more than men. About 3/4, like most autoimmune diseases, women are preferentially disadvantaged because you have two X chromosomes. And so more common for that autoimmune disease in women with rheumatoid. Everybody pretty much gets OA, although women tend to get it earlier. So there's a female predominance for both, but rheumatoid, it's about 3 to 1 women to men. So there's a sex difference, but again, OA, mean onset in the 50s and 60s, and the prevalence just goes up and up as you age. But the mean onset age for RA is around age 50. But of course, that's the mean. So people are getting it in their 30s and 40s. So these are moms and dads that can't pick up babies, they can't go to work, they can't type, they can't work with their hands, they can't drive Uber, etc. So this is really crippling people in the prime of their lives. This is not the arthritis of old people when we're talking about RA. In terms of what's actually going on, normal is on the left. You should have this very thin, single cell lining synovial membrane. You've got this nice cartilage that's the cushioning surface for joints and this joint capsule out here. But your autoimmune system in RA is attacking the joints. You've got all these different inflammatory cells, macrophages and T and B cells that are infiltrating, as well as some minor cell types here. You've basically got this spongy feeling where the synovial membrane is getting attacked. That's all this orange gook here. And where there's no cartilage, at the margins here of this joint, and this is a finger joint, where there is no cartilage, this is the so-called bare area. And that's where this synovium, think about it like the Blob or the Thing from the old style horror movie, basically just starts attacking and eating away your bone. And it doesn't even have to go through cartilage. It's got direct access to the bone. And that's why the erosions in RA are marginal. They're on the margins because there's no cartilage that it has to eat through first. And that's how the erosions in RA are different than the central or the Siegel erosions in osteoarthritis, where they affect the middle here for people who have osteoarthritis. Early on, you may just see some subtle knuckle swelling here at the MCPs and at the PIPs. Over time, clearly things are getting worse, and then these knuckles are very visibly swollen here in the MCPs. And this is somebody who's really had severe and long-standing RA. You've got nodules, and you've got pretty significant deformity. The characteristic deformity is this. It's ulnar deviation. So that means, all the fingers are twisted or turned to the ulnar side, and MCP subluxation. So if this is neutral, again, here are your MCPs, you're subluxing. You're basically pulling them down. And that's because that's the direction of force in your hand. If you think about, where am I stronger? Is it to grip or extend? It's to grip. So the direction of force is down, and it's to basically pull to the right. And because the direction of your hand forces are that way, that's why we see these deformities. So again, I've just given you a few other pictures, and again, sometimes this can be relatively subtle with swelling here. This is somebody who has terrible synovitis at their wrist and lots of deformities of the thumb. This is what we're trying to prevent. And again, these are people in their 40s and 50s. So this is not someone in their 70s or 80s that has this. It's not just an arthritis. There's a lot of systemic features. Not everyone has this, but many do. People have an anemia of chronic disease. They have, evidence of systemic inflammation like a thrombocytosis. We don't see Felty syndrome much anymore. There's a couple different forms of inflammatory eye disease. Interstitial or autoimmune lung disease, that's pretty common and probably of growing importance because there's so little we can do to treat it. We don't see very much cervical myelopathy. If your neck is affected, it can actually destabilize your C1-2 area, and you can put people at very, very high risk if they have long-standing rheumatoid if you intubate them and they go under anesthesia. So cervical myelopathy and instability of the cervical spine, we don't see most of the things on the bottom right anymore, but it's not just in your joints that you have inflammation, that inflammation leaks out. And the paradigm in this example is really, it starts with antigen-presenting cells. We're still not totally sure what the antigen is. People looked for many, many decades about an infectious antigen, never found one, and there almost certainly isn't. There are some known risk factors in the environment. Smoking is one, periodontal disease is another. So there are a handful. There's certainly some genetic associations. If you have a first-degree relative that has RA, you're about 5-fold more likely to have rheumatoid your own self. On the other hand, the prevalence is only 1%, so your risk jumps from 1% to 5% with a first-degree relative, which tells you there's a lot of environmental factors that are at play here. So there's a lot of crosstalk between these different cell types. The chemical messengers of inflammation, cytokines that are secreted by all of these different cells, mediate the damage and the inflammation that we call RA. The way that we treat this is basically to try to break any of the links in this chain. And surprisingly maybe, if you can break any of these links, you can actually do quite well to effectively treat rheumatoid. So we've hitherto had lots and lots of therapies that had kind of some non-specific effects. Methotrexate is probably the best known. When I describe this to patients, that there's all these inflammatory mediators, the details for patients probably not important. Methotrexate and some older drugs are kind of like a Gatling gun. A machine gun, old-timey, can't really aim, hits a bunch of stuff. Off-target effects cause a number of side effects like methotrexate does, but in the more modern era, in the last 15 to 20 years, we've had more targeted therapies, and that's really the focus of this talk. In still my example of a war, it's not a Gatling gun that hits a bunch of things that you can't really aim, it's the sniper. It does one thing, and if the sniper can take out the enemy general, then you can be quite effective in winning the war, and that's how our current therapies work. We borrowed some of the older, less specific therapies, from oncologies and used them at wimpier doses than cancer doctors ever used, but that's really changing in how we're using some of these newer therapies. The paradigm for what happens to people follows really two kinds of courses. This orange line implies relationships with disease activity. Things are normal, it's very active, you kind of beat it back, it may come back, it has this waxing and waning course, hopefully you get disease under control, but the longer that people have active disease, on the other y-axis on the right, the more damage that's accruing, and people end up with the hands and the joint damage like that which I showed you. So active disease basically is destroying people's joints in a way that is irreparable, and really you can't undo that with any medical therapy. And that's why it's so important that we jump on this and not let this continue, because we see irreversible bone and cartilage destruction. This is the old classification system for RA. You had to have morning stiffness, you had to have arthritis in 3 joints, particularly your hand. Symmetric, meaning it has to be on both sides. It's not just my left wrist. It would be both wrists and probably a bunch of knuckles, etc. Serum rheumatoid factor, that's an RF blood test that probably everybody's familiar with. And one of the criteria is radiographic changes, meaning erosions. The problem with that, or meeting these criteria where you had to have 4 of 7, by the time that you get X-ray damage, you really wish that you had treated it earlier so you don't have to have X-ray damage. So you wish you had actually intervened earlier so that some of these features wouldn't be present. So this is our new classification criteria for RA. So this is back to my initial pattern recognition slide. So if you have small joints involved, hand and feet joints, the wrists, for example, and the more you have, the more points you get. So if somebody walks in and says, doctor or whatever your role is, all of my knuckles hurt and my wrist hurts, 5 joints here for all 5 MCPs, and your wrist on both sides, boom, that's 12 joints. So that would instantly get you 5 points, and if they've been hurting or swollen for more than 6 weeks, that's 6 points, and that basically would probably satisfy criteria for rheumatoid arthritis. Now, the other features of relevance, the rheumatoid factor blood test that people are quite familiar with probably, being positive, it would be important. There's a newer blood test called ACPAS. You may know that as CCP antibody. That's a more specific test. Essentially, there are 2 blood tests to diagnose RA, or that are supportive of RA. One is a rheumatoid factor. The other is an anti-CCP antibody. If someone calls me and says, you know, Jeff, I've got somebody with bilateral symmetric hand pain, particularly involving their MCPs, and they're either rheumatoid factor and or CCP antibody positive, I'll see that patient within 2 weeks, because that's the kind of patient that almost certainly has RA, and that's the kind of patient that I can help the most. So none of this, it takes 4 to 6 months to get in to see a rheumatologist. I will move heaven and earth if I can to see that patient. Unfortunately, my quote early arthritis clinics have a whole lot of ANA positive fibromyalgia in them that, you know, are not rheumatoid factor or CCP antibody positive, and frankly have osteoarthritis and a weakly positive ANA, or even a weakly positive rheumatoid factor, and we would check hepatitis serologies, because hepatitis C would be the most common cause of a false positive rheumatoid factor and not indicative of rheumatoid arthritis. So my main take-homes, multiple small joints, typically hands and wrists, and rheumatoid factor and or ACPA or anti-CCP antibody positive, same thing. Essentially, that would help a great deal with pattern recognition, and those are the people that rheumatologists can help the most and prioritize the quickest. I then want to remind you of a totally separate but related condition for the purposes of this lecture. So psoriatic arthritis. This is the arthritis that typically accompanies about 1/3 of people with bad psoriasis. So in fact, we have classification criteria for psoriatic arthritis. So someone who themselves either has psoriasis or they've had it in the past, ideally diagnosed by someone who would recognize it, or has a likely or credible family history. There are some characteristic nail changes. There's pitting of the nails. There's onycholysis or keratosis. These people will be rheumatoid factor and anti-CCP antibody negative. They'll be seronegative, unlike rheumatoids that about 80% of them will be seropositive. They also may have sausage digits, and so the whole digit's swollen, and I'll show you an example of that. The X-ray changes are not the same as in rheumatoid. These people actually form new bone, and the sensitivity and specificity of these criteria are pretty good. They're not perfect, but they're pretty good. And psoriatic arthritis is in a family of diseases called spondyloarthritis. So I point this out mostly to help you think about how to organize this stuff. If somebody has inflammatory back pain, we might call that ankylosing spondylitis. But in fact, if they also had psoriasis, we might call that psoriatic arthritis. But if you tell me that they have Crohn's disease, inflammatory bowel disease, I'd say, oh, that's the spondylitis that's associated with inflammatory bowel or Crohn's disease, so-called enteropathic arthritis. And then what used to be called reactive arthritis, is called reactive arthritis, used to be Reiter's, but medicine doesn't name things after Nazis anymore, so we call it reactive arthritis. So all of these are in the same family, and they basically are more or less manifestations of the same kind of underlying pathology. So these things are grouped together. So when somebody comes in and has psoriasis, I'll ask about back pain like you might ask somebody who you're worried about ankylosing spondylitis, because people sort of forget that, oh, these things live together. I had a call actually from a family friend who's my daughter's cheerleading coach about a family member who has ulcerative colitis, IBD, who has a whole lot of symptoms that sound very inflammatory, and she can barely hold her cell phone, and it's quite possible that she has the arthritis that goes along with IBD. So the main associations are really, if you see somebody with Crohn's or ulcerative colitis or psoriasis that has joint symptoms, you should be thinking of something in this family. We would mostly treat just about everything in this family about the same, but these are folks that we definitely want to see quickly because we can help. So as I mentioned, psoriatic arthritis is distinct from rheumatoid. It's not the same. You know, the musculoskeletal features are different. If you have skin involvement with psoriasis, if you have IBD, Crohn's, or ulcerative colitis, the inflammatory eye disease, uveitis, is different in psoriatic arthritis. It's anterior uveitis typically. We don't see that in RA. And then there's a number of comorbidities that I'll describe just a little bit. Some of the features to show you pictures of, you can get these nail changes where people have hyperkeratosis and a lot of pitting that literally look like just, you know, divots out of the nail. And you'll notice that this joint that's swollen, that's a DIP. Remember I said rheumatoid never affects the DIPs. Osteoarthritis does, but osteoarthritis is not going to have this much swelling and inflammation and tenderness. You may have sausage digits, and you may have enthesitis. So enthesitis, remember what an enthesis is. An enthesis is where a tendon inserts into bone. And these people can have recurrent tendon inflammation where it inserts into bone. So for example, Achilles heel problems. I actually have a good friend who, I looked at his foot, and at the base of his fifth MTP, it was very red and swollen. And I said, you know, Steve, how long have you had that? He said, oh, it's been here about a week or two. And I said, is it always? And he said, but I've had it before, and I know it'll get better in another week or so. And I just take some anti-inflammatories. I said, well, did you injure yourself or what happened? He said, no, this has happened a couple times, but it's usually because I fall or I trip. And often people can make up semi-reasonable stories, but you know, recurrent tendinitis or enthesitis at the same place, the Achilles tendon, you know, any place that a tendon inserts into bone, you know, the elbow, the anterior superior iliac spine, I mean, any place, the Achilles tendon is just one of several. People don't get recurrent tendinitis at the exact same place again and again that's, you know, red and swollen. And I said, you know, I think something else is going on, and actually referred him to a colleague. So the point is that rheumatoid doesn't do some of these things. It doesn't have nail pitting. It doesn't have recurrent enthesitis or sausage digits. It does have synovitis, and so this is again swelling of this MCP, and if you pushed on it, it would feel very mushy. But, and here's another example, it's usually not this red and swollen. This looks so red, I might wonder it's infectious. But again, you know, this is swelling that probably is enthesitis here at the tendon insertion here, and so that should raise your index of suspicion. A few other pictures, so here's again DIP involvement, and rheumatoid wouldn't do that. There's a pattern that it's asymmetric oligoarthritis, you know, it's several but not 10 or 20 joints affected. And then dactylitis, so this digit right here, this whole thing that is swollen, this is the so-called sausage digit that people can have with psoriatic arthritis. And again, these are somewhat unique manifestations for this. In terms of the joint pain that patients might tell you about, your radar should go up for inflammatory pain, so night pain, rest pain, you know, pain that decreases with use. All of that is suggestive of inflammatory joint pain, not the wear and tear pain, you know, with osteoarthritis. And again, if you rest it and people are sitting around for a while, the pain actually increases. For back pain, this can be rather insidious. You know, the 30-year-old weekend warrior who mostly is in a desk job, who thinks he's still in college, that's out playing basketball, you know, who injures his back, but it kind of keeps happening again and again, but he has no other medical problems, so, you know, he goes to urgent care because he doesn't need a doctor because he has no medical problems. But, you know, symptoms that go on for more than 3 months, he can't really tell you when it started. It's not like I was playing basketball and, you know, somebody hit me or I had a fall. You know, it's just been going on a while, but there's no inciting event. He's stiff for at least half an hour, you know, pain that gets better with exercise, and age of onset less than 45 years. So this should raise your index of suspicion for somebody with axial joint pain. And that person, you know, you can go get MRIs, but probably needs a CAT scan or an MRI, because if you're looking at the sacroiliac joints or the spine, you're looking for bone inflammation. You're looking for osteitis, and an MRI can pick that up. Plain x-rays are not good for that. The spinal x-ray changes that are quite classic, so syndesmophytes, these are sort of wispy, bony bridges here. Down here are osteophytes. You know, you might see this a little bit in people with degenerative arthritis, but you know, these sort of wispy, bridging syndesmophytes here are quite distinct from what people might think of as bone spurs or osteophytes like you would see in OA or in DISH. And then here, asymmetric sacroiliitis, where, you know, you see the SI joints here, but you can't see much of any of that here on the patient's left side. So in terms of therapy, what can we do about any of this? There's a whole bunch of therapies, and as I mentioned, they're targeted. They do one thing. So one of the cytokines that is an effector of inflammation is tumor necrosis factor. This is the general that's causing lots and lots of inflammation, and there's medicines that we can use to target that. Interleukin-1, another cytokine that mediates inflammation. Interleukin-6 that does a whole host of things. The T cells talk to a number of different other cells, antigen-presenting cells and each other, and B cells. We can block that. We can deplete B cells, and then there's a newer pathway called Janus kinase inhibition. So basically there's a bunch of ways that we can modulate the immune system with our current therapies. This is not the old days of methotrexate or gold or sulfasalazine that do a whole bunch of stuff. Frankly, we still don't really know why methotrexate works, but we really do know at least what these are doing because they're mostly only doing one thing. For the most part, they're biologic drugs. So many of them are monoclonal antibodies, and this is kind of the typical structure that you may be familiar with as a monoclonal antibody. Some of them are recombinant fusion proteins, so this is etanercept or Enbrel. Infliximab, that's Remicade. Adalimumab is Humira, and golimumab is Simponi, if those names are more familiar. There's certolizumab. This is a pegylated molecule. It's the same FAB prime fragment, sort of the business end that attacks the target, but then there's this big bulky PEG molecule. That one doesn't cross the placenta, so we kind of favor that drug for a woman who's pregnant. And then there's a whole signaling pathway called Janus kinase inhibition that we can use to modulate RA, and that's now used in psoriatic arthritis as well as in ulcerative colitis. So the JAK drugs that work through the Janus kinase receptor and the STAT receptors, there's now 2 drugs. They have the effectiveness of a biologic, and they work just as quickly, but they're oral pills. So the point is, there's a lot of drugs, they affect the immune system in different ways. In terms of how we use them, there's a number of different guidelines, and I'm going to just point out some of the highlights because I suspect many of you are not rheumatologists. In these guidelines, a key feature, we want to diagnose people early. Early is less than 6 months. If it takes 6 months for you to get a patient that you suspect has RA or psoriatic arthritis in to see a rheumatologist, we've already failed as a specialty. So that's where I said, if you have somebody that has small hand joint pain and a positive rheumatoid factor or anti-CCP, I'll see them within 2 weeks because I can help them. We want to treat them early. Many of you may remember the old med school pyramid that you started with NSAIDs and with anti and steroids, and you sort of layered on these therapies. We don't do that anymore. In fact, if anything, we flip that pyramid upside down. We treat appropriately and aggressively because we want to get people to remission. There is a window of opportunity that if you get them early, the likelihood you can get them to remission is much greater than if they've had disease for a year or two and it's set up shop, and at best you can only control it. So we can actually get people to remission, the word that, again, 15 years ago, we never would have actually described. We may need more than one medicine. We often will use methotrexate with something else, plus or minus some low-dose steroids, prednisone of 5 milligrams kind of thing. But prednisone and NSAIDs would basically be malpractice for an RA patient these days in the modern era as the long-term treatment option. And in fact, I've sometimes apologized to patients and said, Mrs. Smith, I understand the only thing you want is, your meloxicam or your celecoxib and some prednisone. This is bad rheumatology care. Not that this is at all about me, but I am embarrassed that this is what you're getting. I understand you don't want anything else, and will often try to negotiate with her that, her prednisone of 10 milligrams plus is actually, causing or contributing to her diabetes and her weight gain and cataracts, etc. So anyway, the point is that NSAIDs and steroids alone for anyone with these kinds of arthritides is bad care long term. Will we use them as adjunct therapy and use them early with other things? Absolutely, but by itself, that's a bad long-term option. And we want to keep striving for remission. That is our new treatment goal. It's in these and many other guidelines. Nobody, when they go to the cancer doctor, says, you know what, as long as you shrink the tumor some, I'm good with that. They say, I want it gone. I want to be in remission. And that's the same paradigm that we have now for autoimmune diseases. There's a bunch of different molecules and cell types and a lot of different inflammatory cytokines. You know, this is a cartoon schematic, but it's complicated. This is a complex disease, and we've got a lot of different therapies. We have anti-TNF therapies, and you can read the generics, but just for recognizing the names. So Enbrel and Remicade, we now have biosimilar. Humira, Simponi, Cimzia, the JAK drugs, this is Xeljanz and Olumiant, and then Rituxan, and Orencia, and Actemra, and Kevzara, Stelara, and Cosentyx and Taltz. So you'll notice that 5 of them are anti-TNF drugs. They block one cytokine, and these others deplete B cells or prevent T cells crosstalk. They block the interleukin-6 receptor. The newest ones in psoriasis and psoriatic arthritis and IBD will block interleukin-12 and 23 or interleukin-17. So the point is, we have a lot of fancy ways to block the immune system, and these medicines work quite well. So this is an example, and I could show you a number for almost any of these molecules. So for people that started early RA, starting methotrexate or starting adalimumab, which is Humira, about 25% of patients get into clinical remission at year 1 and 2. But if we use both together, it's almost half. So this and this kind of data is why we typically use 2 drugs together, and almost half of people in clinical remission is pretty darn good. And assessed a different way, you know, you basically get the same result. So that's the notion here, is to use multiple drugs together. If I showed you people who had 10 years of RA, all of those bars would be a lot lower because people can't respond as well because they've already accrued lots of damage. The newest drugs, so the Janus kinase drugs, so Xeljanz would be one of them, you know, pretty much on par in terms of the response rate with Humira. This is from the New England Journal, and the point is we now have drugs that are biologics that have to be given by injection or infusion, or by mouth, typically once a day. So you could think of it as, you know, a biologic in a pill. They're not really biologics, but they have pretty comparable efficacy and safety. Unfortunately, they're really, really expensive for patients. So that's why, you know, for these different drugs, I've just given you a sense about, you know, what their sales are in the United States. You know, this is billions and billions of dollars here. The medicines are about $3,000 or $4,000 per patient per month. So if you don't have good insurance, you can't afford any of this. So there's a lot of money here, which frankly has been partly why rheumatology is back on the map, because typically we are now the most expensive drug that any, you know, pharmacy or health plan, PBM, specialty pharmacy, et cetera, has to pay for. On the other hand, you know, about half of people getting to remission, you know, the mom who can now take care of her child, you know, the person who's in their 40s who can go back to work and isn't applying for disability 5 or 10 years into their disease, you know, this has been life-altering for many people, but it comes at high expense. There are a number of reasons why we would choose one over another. The details perhaps are less important for this talk. Patients care a lot about route of administration, so I could give you an IV therapy, you know, every month or 2. I could give you an injection that you take your own self once a week or once a month, or a pill you take every day. So those are various options. There's a few other features that we don't have to get into a whole lot, except that I would point out there are certain concomitant health conditions. If you have psoriasis, some of these definitely will work better than others. For RA, on average, they're mostly about the same, but for psoriasis and psoriatic arthritis, especially for the skin part, or if you have Crohn's and the arthritis that goes with Crohn's, some of these will work better. And then the safety is another concern. And this is where, you know, you may be asked by patients, you know, about the safety. And there's a lot of, I think, both fear and concern about the safety profile for some of these therapies. So I've given you the highlights, but these really are mainly the safety issues. Because we are modulating and perhaps suppressing to some extent the immune system, serious infections are always a concern. On the other hand, the rate of serious infections in the average population of people with RA or psoriatic arthritis or ankylosing spondylitis, you know, it's 2 to 5 per 100, which in my book is fairly low. Malignancy, it's about 1 out of 100. There's a concern for GI perforations with some of the interleukin-6 drugs. Shingles is about 4 out of 100. So, you know, these are real risks, and people have heart attacks at a rate of about 1 to 2 per 100. If you have rheumatoid arthritis, you are... You are more likely to die about 5 to 8 years earlier of a heart attack if you have rheumatoid arthritis. So that's pretty relevant. But what we should be concerned about is not just what the risks are, but what the extra risks are. With serious infections, about 1 to 3 additional people per year will have a hospitalized infection. You know, not tuberculosis necessarily, but you know, pneumonia, cellulitis, things like that. There is no incremental risk for cancer. You know, not lymphoma, not breast cancer, not colon cancer, etc. You know, there is no extra cancer risk. It's taken us 20 years to sort that out, but there is no excess risk. So you get the idea that there are these risks. These are relatively low. The incremental risk for most of them is not zero. We're respectful of them. You know, an extra 1 to 3 out of 100 people is bad if you're the one person out of the 100 that had it. So because sometimes patients aren't numbers people, you know, visual quantification is very helpful for many people. So, you know, you could say, if you believe that the rate was, you know, 2 out of 100 and it was going to go to 4 on this new drug that you're giving them that affects their immune system, you could say that the rate or the risk was double, and that would be true. On the other hand, if only 4 out of 100 people are having the problem, then 96 out of 100 people are not having a serious infection on this drug, which most people say, well, that's pretty good odds. I have a 96% chance to not have a serious infection. We created a tablet app, and this is based on real data. You know, for somebody who's thinking of starting one of these drugs that we've been talking about, this is the likelihood that you get better. Those are all the blue people. So 60, and probably this is an underestimate, it's probably more like 70, out of 100 do really well. And you know, here's your risk of a serious infection, like a pneumonia or cellulitis. Yeah, it's about 3 or 4 out of 100 people. Not on the medicine, it's around 2. But again, all those people in gray, they didn't have the infection that they saw on television or the direct-to-consumer ads worried them about. And you know, just for kicks, I've asked people who were worried about this, who had said, you know, Dr. Curtis, I saw that ad, there was that golfer guy on TV, and he looks happy and shoots a great golf game, and his psoriasis is really clear. But, you know, it says you could get lymphoma or tuberculosis and die, and I just don't want that to happen. So I ask people anecdotally, you know, how often do you think that actually occurs? What do you think the risk of TB is on that TNF drug we're talking about? People, I said you don't have to be right, I'm just curious kind of what you're thinking. Mostly I get answers like 10%, meaning they believe that on any of these drugs, this one, you know, Enbrel or Humira or Remicade, that about 10% of people were getting tuberculosis. I said the good news is it's about 2 out of 1,000. So my point is really that risk communication about the safety of any of these therapies, yes, they affect the immune system. These are a whole lot safer than most people think, but if you just say the risks are low or this is uncommon, and you don't say, look, only 3 out of 100 people per year will have an infection on, you know, Enbrel or Orencia or whatever we're talking about, you know, that's a very different feel, because when doctors and nurses and clinicians use the word, you know, it's rare or it's low, I'd argue you have no idea what patients think when you just use a word that you can't quantify or you can't help people visualize. The 2 other topics that I just wanted to turn attention to as we're kind of wrapping things up. The first is there's concern that if people are on one of these drugs around the time of surgery, that you need to hold the drug before surgery. So the concern for orthopedic surgery, for example, they'll get a serious infection within the first 30 days, or even worse, they'll have a prosthetic joint infection, which will be catastrophic. So we did an analysis looking at various times to stop this infusion drug Remicade, where we look at, you know, what happens if you stop less than 4 weeks from surgery, or between, you know, 4 to 8 weeks, or 8 to 12, etc. You know, both for serious infections and both for prosthetic joints infections, there is essentially no difference, meaning people have no need to stop before surgery, and yet I can tell you I've had people literally in tears where this woman said, my surgeon told me I have to be off of my whatever for 3 months and I am dying and miserable here, and you know, is there really data that justifies his requirement, because you know, this is absolutely awful and I'm in such bad shape I don't even think I can rehab because I can barely move. So my point is that people don't really need to be off these drugs for very long. Certainly no more than 2 weeks, and this data might argue that they don't actually need to stop it much at all. The few remaining controversies that I at least want to touch on, because I think they generalize to people of all specialties. Somebody has rheumatoid or psoriatic arthritis. You know they have an inflammatory arthritis. They're hurting. a key conundrum for all of us who take care of such patients. Where is that source of pain? Is this just your rheumatoid is not well controlled? Is this just you hurt because you've had rheumatoid for 20 years and you know your hands look like those pictures? You've had this terrible damage. You know, the pain hurts more when the weather changes. That is in fact a real thing, but it's probably not inflammation related. It's damage and osteoarthritis related. So is it coming from damage, in which case it's not that their medicines aren't working. You don't need to give up and change their immune system in a different way. It's due to damage. Or do they have terrible fibromyalgia, anxiety, depression, they're not sleeping well, etc., or some other comorbidity, you know, diabetic? So this is tough to sort out and is something that we spend a lot of time thinking through. But my main point is to not assume that every time that somebody with rheumatoid or one of these kinds of arthritis hurts, that it means that their rheumatoid is doing badly. You often have to look deeper. About a third to half of these people will have clinically meaningful depression, so that plays into all of it. Obesity, diabetes, metabolic syndrome, hyperlipidemia, etc. This is partly what puts people at a 50% increased risk for heart attacks and for stroke. And in fact, if you're managing these people's cardiovascular risk, thinking about statin therapy or how aggressive to be with managing hypertension, any calculator you use to estimate risk, that could be SCORE or Framingham or the ACC-AHA calculator, you're recommended to multiply that predicted risk by 1.5. So if a woman, let's say she's 50, she smokes, she has a bit of high blood pressure, if her risk coming out of that risk calculator that you use was 5%, you're supposed to multiply by 1.5. That would make her risk 7.5% for a heart attack or CVD event. Probably you'll put that woman on a statin because she has RA and the incremental CVD risk that it confers. And then extra articular features, so this is the pneumonia that is on its third or fourth round of antibiotics that you have to think, maybe this isn't community-acquired pneumonia having failed 3 or 4 rounds of therapy. Maybe this is an opportunistic infection because biologics do affect the immune system. Or maybe it's not even infectious at all. Maybe this is interstitial lung disease, sort of the IPF of the autoimmune world. It's not idiopathic, obviously. It's related to their underlying autoimmune disease. But just think through, particularly lung issues, bronchiectasis, opportunistic infections, and ILD. And then finally, vaccination. You're supposed to vaccinate anybody with any of these rheumatic diseases that are going to be on or are on immunomodulatory therapy, pretty much with flu and pneumonia vaccine anytime that you see them, even age 18 and above. So we tend to want to be more aggressive with vaccination. The live virus vaccine for shingles, Zostavax, probably stay away from that one for anybody on a biologic. Shingrix, we're not real sure what to do with. It works well in the healthy people, but the adjuvant is so potent, it really may rev your immune system up, causing disease flare. So until we have data, I think we're probably cautious, and there is no recommendation to use for anybody with any rheumatic illness on any of these medicines. So with that, I'd like to thank you very much for your interest and attention and field any comments or questions.
What about those who refuse vaccination?
Yes, so if they refuse, then obviously there's not a whole lot you and I are going to have to say about that. I'll find out why they refuse. Occasionally it's based on misconception. I think that the flu shot will give me the flu. Well, we know that's not true if you're using an inactivated flu vaccine, but you do feel cruddy for a couple days, and that is a real thing. And if that's why you're refusing, I'll tell them, you're at higher risk because you're immunosuppressed, maybe you're on some low-dose steroids, etc. You have a greater need for it, and I'm recommending it. But if people say no and they understand, that it's not going to give you the flu, but yeah, you may feel crummy, and like people can die of the flu, and you're at higher risk and you still don't want it, you can't really argue with that and just document that people decline. But I will try to have that conversation to talk you into it. As people probably know, for flu, there's a trivalent, there's a quadrivalent. Some years it works well, some years it doesn't work very well. Egg allergy isn't a thing anymore. You can get recombinant, so that's not a reason nor an excuse. I don't know what your all policies here are. At UAB, if you as a healthcare provider in any sort, or even someone who works for the system, if you don't get a flu shot, you're fired. So you actually have to document evidence of that by December 15th, or they consider it tantamount that you have voluntarily resigned your job. which is what I'm calling being fired. But I don't know if you guys have that here yet. I mean, so you're familiar with it, and I will say, look, this is so important that everyone in the health system, even someone in an administrative capacity, has to get this. And again, it's often not an easy conversation if people have longstanding, almost religious beliefs that they shouldn't be vaccinated, but I'll certainly try. Yes, sir.
Are there any dietary changes or over-the-counter preparation nutritional supplements that would help somebody in that condition?
Yeah, so diet and nutrition for people with rheumatoid or inflammatory arthritis, etc. Unfortunately, not really. The microbiome is hot, and for people with Crohn's, for psoriasis, for ankylosing spondylitis, people are actually testing as intervention, specific carbohydrate diets or Mediterranean diets, etc., that might help your Crohn's and the arthritis that goes with it, or one in the spondyloarthritis family. We're still accruing that. I tell people, avoid smoking, avoid caffeine because that can amplify pain, anything that messes up sleep. In terms of lifestyle, exercise is a good thing. People need to be encouraged, but there's no specific diet that has been known and proven to help other than that published in, the Journal of Anecdotal Evidence. Yeah, glucosamine and chondroitin. So now we're not talking about rheumatoid or psoriatic arthritis. I put glucosamine and chondroitin in the might help, can't hurt category, and then I ask what people are paying for it. Sometimes you'll find that people are paying $1, $1.50 a day on a fixed income, and if it was free, I'd say, sure, might help, can't hurt. If you're going to do it, you need to try it for 90 days, and if you're not convinced, then stop and see if it helped. To my knowledge, there's no known side effects. There was a NIH-funded, head-to-head trial that included both placebo and Celebrex as a comparator. There was basically no effect. It was a totally negative trial. No one will ever repeat that trial again. But again, because the side effect profile is relatively benign, I'm not averse to it. One rheumatologist, when this was presented at our annual meeting, stood up and said, you know what? I'll take a 30% placebo response that's safe as long as it's not breaking the bank for my patient. So, bring it on if that's what they want to take. So I'm fine with it. I'm just unimpressed based upon any rigorous data. Any other questions or comments? Okay, thank you so much.